For ages, I'm known to be a neuro-oncologist, and GBM was my first interest more than 25 years now. Many people think that GBM is static for the last 20 years, but a little bit of work is done in the last 3-4 years. I'll try to be fast, not to skip the Friday prayer. So this is my ambitious overview. A little bit of introduction. What about radiotherapy? What about temozolomide, the pseudo progression, NCCN guidelines, and new update. Glioblastoma multiforme is a World Health Organization grade 4 astrocytoma and the most common and aggressive primary brain tumor in North America. Estimated age-adjusted incidence is 3 per 100,000 population. It occurs more commonly in males and is typically diagnosed in patients in their 6th or 7th decade. Now it's coming in very much younger ages. This was the way I was preparing my doctoral thesis on GBM some 25 years ago. It was that simple. Diffuse astro, anaplastic astro, and glioblastoma. And glioblastoma, since that time, was known to be fatal, with 5-year overall survival not more than 3.4%. Things are so much different right now. This is a quote from the WHO classification 2021, where things are meant to be like they are telling us M&M, morphology and molecular. So we are dealing with different types depending on the molecular entities of glioblastoma. The clinical presentation, most common symptoms at presentation: aggressive neurological deficit, motor weakness, headache, seizures. Many patients' diagnosis of brain tumors is made several months after appearance of initial symptoms, especially in patients with intermittent headache or what we call unclear cognitive or motor function. This is how images are looking, what we call donut appearance in the MRI, where the enhancement is at the border, which is a very fast growing border, and necrosis in the middle. The necrotic areas in the pathology report are the diagnostic of GBM. When you are not reading necrosis, it's not a GBM. First line of treatment is always surgery, but which surgery? It's maximum safe resection. So if it is not safe, we are not going for it. If it is not maximum, meaningly more than 75%, please, the surgeon would have only a biopsy, stereotactic biopsy, which is a very safe procedure, and then proceed for the treatment, which is our job as an oncologist. What about the radiotherapy technique? This was for ages what we are aiming for in conformal planning or 3D planning. Many of our centers is still adopting this way of treatment, where we are dealing with the planning tumor volume, which is the clinical tumor volume plus ½ centimeter, and we use a double contrast material to delineate the tumor. For the high grade, let us skip to here. The first phase, where the large volume, what we call the planning tumor volume with T1 enhanced plus the edema, or T2 with the edema, vasogenic edema all around, as the border to the phase 1, 40 gray, then phase 2, localized to the tumor, we are continuing to 60 grays. Here is the how we fix the patient with the thermoplastic mask, and this what the planning or the color wash of the planning looks like, and this what we see every day in our radiotherapy suits. What about novel radiation approaches? This paper was published a year ago or something, where we use multi-parametric MRI, metabolic MRI, functional imaging to target volume delineation in radiotherapy is an active area of current investigation. New protocols with protons, carbon ions, boron neutron capture therapy are currently being evaluated. Are there any way to be in the guidelines? No, they are all investigational treatments, but I'm bringing this paper especially for the last 3 lines. Several re-irradiation strategies exist to recurrent patient, including stereotactic radiosurgery, fractionated stereotactic radiation therapy, hypofractionated radiotherapy, pulsed reduced dose rate radiotherapy, and particle therapy like the proton. This is the most updated comparison of the target delineation between the different bodies that are giving the guidelines for treating glioblastoma. And what we can see really is the limitation of the delineation of the field to a more limited field than we used to be 3 centimeter. After the edema, it's not anymore like this. You are going to 2 centimeter after the border of the tumor, or I can give you like this, the T2 images, which is the tumor cavity plus only 5 millimeters. So this is giving us an idea about how the radiotherapy is becoming more and more limited, because the long-term results with the effect on the cognitive function are more deleterious than we thought it would be. So we are not anymore that generous with radiotherapy fields. Stereotactic radiosurgery and hypofractionated radiotherapy for glioblastoma. This is the new trend at time of recurrence, not at the first line of treatment. And having the hypofractionated radiotherapy is adopted right now, maybe for 5 years, especially in elderly patients. For patients who are elderly or have poor performance status, the standard of care is evolving, where we are dropping from this usual 60 gray conventional in 30 treatments to the 40 grays in 15 fractions, which, by the way, became the standard of care during the COVID in most of our centers. What is the ever and lasting protocol we are dealing with glioblastoma? It's STAB protocol, which is right now still valid. I used to brag with my friends with this slide dating since 1976, one of the earliest publication about the concomitant treatment of glioblastoma with CCNU and radiotherapy, till we reach 2005, which is the STAB protocol, which is still valid till now after more than 17 years of concomitant temozolomide and radiotherapy, followed by adjuvant temozolomide. Temozolomide induces an arrest of G2M in glioblastoma cell lines, and this is the most radiosensitive phase in the cell cycle. It inhibits radiation-induced invasion, and the drug is given concomitantly with radiotherapy, not sequentially. This was the earliest result that showed that there is overall survival benefit and progression-free survival benefit of this protocol, which was published in New England Journal of Medicine 2005. What are the side effects of treatment? Patients with malignant glioma have been described with subacute treatment-related reaction, with or without clinical deterioration, showing edema and sometimes contrast enhancement on MRI, suggesting tumor progression. Patients recovered or stabilized spontaneously, often without deficit. This is what we are dealing with as pseudo-progression. Early disease progression was defined as progression more than 25%, noted on MRI, 4 weeks after radiotherapy. Real early progression was diagnosed if the patient with early progression developed additional disease progression within the following 6 months. So don't rush to think that your patient is failing and the tumor is growing, except you are having a sequence of MRI along the first 6 months to say that the tumor is steadily growing, because you might have what we call pseudoprogression that can occur in about 20% of patients and have been treated with temozolomide chemoradiotherapy. This lesion decrease in size, stabilize without additional treatment, often remain clinically asymptomatic, only with a little bit of steroids and dehydrating measures. This how things getting worse. We think that the tumor is growing, and after about 6 months that it returns back to almost what was after surgery. So patient with progression within the first 3 months of radiotherapy should be excluded from trials of recurrent glioma. You should be treating them as if they are primary glioblastoma unless histological proof of recurrence is obtained. Also, the new images with new technology of functional MRI would show that this is the tumor. We think that there is a progression, and after only 3 months, it decreases again, and it proved to be pseudoprogression. Are we having a resistance to temozolomide? Definitely. This is the idea about MGMT, which is enzyme 6-methylguanine DNA methyltransferase. This enzyme removes methyl adducts on the 6th position of guanine, and patients with low MGMT levels, that's to say those with reduced capacity to repair DNA damage, displays significant longer survival and or higher response. We know this information since 2007. So MGMT is becoming part of your diagnostic tool to know the prognosis of the patient and how long would you continue your temozolomide treatment or temodal. This was one of the earliest papers published in 2008 about the MGMT promoter methylation. What about the NCCN guidelines? This is NCCN guidelines for the clinical impression, surgery, and pathology. And this is what about the dividing the patient according to their age. Over 70 years old, they are to be treated with one of your treatments alone, hypofractionated, with or without temozolomide, sometimes temozolomide alone without radiotherapy. Less than 70 years with good performance status or poor performance status. With good performance status, they are now dividing them into methylated or unmethylated cases. With the methylated cases, we consider clinical trials, and we will go for standard brain radiotherapy concurrent with temozolomide. And the unmethylated, I can go for even standard brain radiotherapy alone. And again, we know our adjuvant treatment could be divided according to the methylation status. For the recurrence, if it is diffuse or multiple recurrence or the local recurrence. If the local recurrence is resectable, go first for resection, then consider clinical trial if the patient is eligible, going for systemic radiotherapy, and go for re-irradiation. If it is unresectable, we would go evenly for palliative or supportive treatment, or consider alternating electric field. I'll speak about it in a moment. This is the principles of surgery. As I told you, gross total resection when appropriate, minimal surgical morbidity, accurate diagnosis, which is the best thing to do. For the high-grade glioma, tumor volume are best defined using pre- and post-operative MRI. Don't rely on the pre-operative only, because the tumor is going to shrink a little bit, and many of the normal brain tissue will be included in your radiotherapy field. So you should compare between the pre-radiotherapy and the pre-surgery and post-surgery MRI before planning your treatment. And in the guidelines, we are here speaking about the 40 grays or the 30 gray in 10 fraction for the poor performance older patients. And again, the re-irradiation is there. I'm highlighting here the recurrence of glioma can be managed with re-irradiation in selected scenarios when clinical trial options are there, up to 35 grays in 10 fractions, better to be done after a year from your primary irradiation, not very close to the primary irradiation. A lot of trials are here now for the chemotherapy or recommended regimens. Here is the preferable regimen, which is the radiotherapy and adjuvant Timodal or PCV. And here, at time of recurrence, we will use the PCV, lomustine, and bevacizumab or Avastin. Our recommended protocol are there depending on the older lomustine or carmustine, and the new trials are now heading towards the molecular element of the tumor with studying BRAF mutation, the NTRK gene fusion, with the use of different immuno-oncology or revisiting the older treatment as we have been discussing earlier today with Professor Yusri Wasif, the etopsid, the carboplatin, or the cisplatin at time of recurrence. It is there. Irinotecan is not there anymore. So, again, for the adult glioma, glioblastoma, we are having a lot of trials in using the new immuno-oncology or targeted therapy, but all are not category A proved. And for the glioblastoma, we are now dealing with very much progress in the pathology, IDH wild type, TRT mutation, EGFR amplification P10, and for the grade 4, we are seeking H3A mutation. For the astrocytoma, IDH, ATREX, and P53 mutation, and the BRAF fusion are to be tested. We are having those in Egypt right now, but still the pipeline is not providing us that fast with the proper medication to be used. At time of treatment, at time of recurrence, we are having this systemic review and meta-analysis of re-irradiation. There are no dose response above 36 gray. So we are not treating with the same primary dose. We should reduce our dose maximum to 36 gray after almost a year after your primary radiotherapy treatment. Using a very field, we are preferring to use it in a radiosurgery machine to limit the treatment even to 5 treatments. So we can use the gamma knife, the cyber knife, and we are pleased that cyber knife is there in Cairo at 57 and the Linux-based system. What about the tumor treating field? This was the new interest of Dr. Shtab, and I'm always criticizing him and bragging him in the conferences. This is this have been revealed in 2017, where was thinking that this is the future of putting an electrode inside the tumor and giving pulse therapy of electric field to the tumor. It's not in Egypt, it's in the Gulf, in Emirates, some European countries, but it's not proved to be the standard of care. FDA approved using Avastin in glioblastoma recurrence, and bevacizumab with temozolomide have been there at least from 2015, proved by FDA in 2017. I'm having 2 slides only, just 2 slides. And bevacizumab could be rechallenged. What about immunotherapy? Everything is used now. This was a paper published in 2018, and this was published even last year in March, dealing with the dendritic cell vaccines, the checkpoint inhibitors, with pembrolizumab and other drugs, and the CAR-T is the most used right now trials for the recurrent cases of glioblastoma. So in conclusion, concurrent chemoradiotherapy is still the mainstay of treatment. Pseudoprogression is to be accounted for. At time of recurrence, redo surgery, re-challenge temozolomide plus or minus bevacizumab is advised. Hypofractionation is acceptable right now, maybe for all cases. Re-irradiation is now part of management with IMRT or SRS. Many targets and immuno-oncology are in active trials, but none is in the guidelines. I hope I didn't bother you and brain pumped with a lot of information, and thank you so much.